This video is for patients with atrial fibrillation who are trying to decide whether to get treatment to lower the risk of stroke.
Hi, I'm Dr. Fred Masudi. I'm a heart doctor at the University of Colorado. This video is for patients with atrial fibrillation, also known as AFib, who have an increased risk of stroke because of their AFib. You may have a new diagnosis of AFib and may be learning about the different treatment options available to you. This video will help you understand the stroke risk associated with AFib, the typical treatments and their associated risks, a comparison of the treatment options, and possible alternative treatments. I will be reviewing these topics so that you can discuss them with your doctor and decide which option may be best for you. It may be confusing that your doctor is talking to you about stroke prevention just because you have AFib. And I know that talking about strokes can be scary, but knowing how you can help reduce your risk for stroke is important. To start, we are first going to explain what AFib is and why it can increase the risk of having a stroke.
Patients with AFib have a heart rhythm that is not normal. The top parts of the heart, called the atria, are not beating in an organized way. This can increase the risk of forming a blood clot in the atria. The most common place where blood clots form is in a part of the heart called the left atrial appendage. Blood clots may break off, enter the bloodstream, and travel to the brain. This blocks blood flow to that part of the brain and can result in a stroke. Stroke risk with AFib.
Due to several different factors, such as your age or other medical conditions, you have an increased risk of stroke because of your AFib. Most people in your position do something to help reduce their risk of stroke. There may be several options available to you for stroke prevention. Let's first discuss what it looks like to get treatment versus not getting treatment.
Stroke risk depends on many risk factors. While we do not know your specific risk factors and cannot provide your exact stroke risk, we can give you a rough estimate. Without treatment, each year, somewhere between 3 out of 100 to 15 out of 100 people like you will have a stroke, depending on your exact risk factors. With treatment each year, this risk is cut by more than half, to somewhere between 1 out of 100 to 4 out of 100 people like you. For a more personalized risk estimate, ask your doctor.
The numbers presented in this video are a summary of information from recent medical studies. However, no one can know what will happen to each individual person. Patients similar to you have gone through this decision-making process and will share their experiences with you throughout this video.
It was approximately 4 years ago when I was diagnosed with AFib. Didn't even know what AFib was. I learned that stroke risk was really high when you have AFib.
It had probably been 15 years since I've been to the doctor for anything. I mean, that was a cold or anything. So it was kind of a surprise to me to find out that I had AFib for starters, and then the fact that it limits you to what you can do and how you can do it. It was devastating to find out.
My doctor, in explaining AFib, went on to include the fact that I had increased stroke risk for the rest of my life because of the AFib. So I was concerned about long-term effects, and I wanted to do whatever I could, quite frankly, to try to lower that risk.
Benefits and side effects of treatment.
Hello, My name is Pratiti Kazani. I'm a heart doctor at the University of Colorado. I'm here to discuss some treatment options and their potential risks. If you choose to get treatment for stroke prevention, the main treatment option is a blood thinner medicine. Blood thinners, also called anticoagulants, help prevent clots from forming in the blood and causing a stroke. While blood thinners have the benefit of helping to prevent stroke, they also come with the risk of bleeding. A major bleed is bleeding that requires going to a hospital and getting treatment. This can include bleeding in your brain, stomach, or intestines. Sometimes these bleeds can lead to long-term problems or even death. Because it's harder for your blood to clot on blood thinners, minor bleeds like nosebleeds and bruising are also more common. Some people have a higher risk of bleeding than others. Talk to your doctor about your individual bleeding risk. Blood thinners provide a trade-off. They will increase the risk of bleeding, but they also help prevent stroke. In most cases, strokes are more common and serious than bleeding. This is why doctors generally recommend that people like you take a blood thinner.
The reason I decided to take an anticoagulant as opposed to not taking anything is that the doc said if you have a stroke, you won't be happy with the outcome. And so it was better to go on Coumadin or warfarin so that minimize the risk of that occurring. And I certainly like the idea of not running the risk of having a stroke as opposed to not.
The reason I decided not to take it with my doctors was that I had 2 GI bleeds within a year, and they figured that the bleeds might have been caused by the Coumadin.
Comparing treatment options. Blood thinners.
There are several different blood thinners available for stroke prevention treatment. You may be learning about these medicines for the first time, or you may already be on one of these medicines and considering different treatment options. Warfarin, also known as Coumadin, has been used for a long time as the go-to therapy. Direct oral anticoagulant medications, or DOACs, are newer medicines that do the same thing as warfarin. Research studies now suggest that DOACs work just as well and in some cases better than warfarin. There are several different DOACs now available. Some patients may not be candidates for DOACs due to problems with their kidneys or heart valves. We will now go through the similarities and differences between warfarin and DOACs. Let's first look at the side effects. As mentioned before, both warfarin and DOACs have an increased risk of major and minor bleeding. Compared to DOACs, warfarin appears to have a higher risk of major bleeding, including bleeding in the brain. Bleeding in the brain is not very common. Warfarin has other side effects of skin rash and anemia, which is a low blood cell count. DOACs, depending on which one you take, can also have side effects of skin rash and anemia, and can also cause stomach upset or pain. Now, let's discuss lifestyle considerations. Both warfarin and DOACs must be taken daily, usually once or twice per day. Warfarin requires regular blood testing to make sure it's working correctly. Warfarin can also be affected by what you eat, so you may need to keep a consistent diet and avoid some foods. DOACs do not require regular blood testing or change in your diet. Lastly, warfarin is usually less expensive than DOACs. However, follow-up blood testing for warfarin may cost additional money or copays. If you choose to take a blood thinner, talk to your doctor about which one may be best for you.
He told me about the Pradaxin, that it was one of the pills that I could be on and still kind of do what I wanted to instead of having to be tested all the time. So I went with the Pradaxin, which is pretty expensive, but it's worth right now with me wanting to travel.
I have had occasional bruising that I have to be a little bit sensitive to. You're much more susceptible to bruising, but I really haven't experienced much of a problem with that. You have to be sensitive to what your diet is. It doesn't mean that you're precluded from eating a lot of things, but you just have to be wise in terms of what you're doing, the dosage of warfarin that you're on, and how that interacts with the vitamin K that you're taking in normally through your body, and make sure that you try to keep those two items in balance.
Getting cut and bleeding, because what I want to do in life considers is some of it's dangerous. I'll put it that way, and so that part concerns me, of getting hurt and being out somewheres and not being able to get to medical help in time because you're taking warfarin, your blood's thin, and so yeah, that's the only thing that really concerns me about it.
Well, I don't have to worry about what I eat, where I go, what I do. I don't have any of those concerns whatsoever. I did have a GI bleed. It was a slow GI bleed, but it was enough of a concern that you couldn't leave it alone.
Comparing treatment options. Closure device.
For those people with a high risk of stroke, but who also have problems with taking blood thinners in the long term, a procedure option may be available: the left atrial appendage closure device, also known as the Watchman. It is important to note that the closure device is appropriate for only a small number of patients with AFib. In order to be eligible for the closure device, you must have a high risk for stroke, show that you've had or are likely to have problems taking blood thinners over the long term, have had a discussion with your doctor about the possible benefits and risks of the closure device and whether it is right for you.
The way I felt about the Watchman device was that I felt at first a little bit angst about doing it because it was going up into the heart, but then I thought about it, and once they showed me the video, it seemed like a very good thing to do.
He was on the Coumadin, and after he had the GI bleeds, then I worried if he would have another one. And I think that was my biggest fear.
With me falling as often as I do and being clumsy, it would really help. Then I wouldn't have to take the blood thinner anymore, and I wouldn't have to worry about the internal bleeding. He did the scope my heart, and then found out that it was, told my daughter that it was just a little bit difficult to do. So she asked me not to do it yet, to think about it a little bit more. Her worrying about it made me kind of question it.
The closure device may be covered by insurance, but Medicare has rules on what type of patient can receive the device. Talk with your doctor to understand if you would be covered.
What is the closure device?
Hello, my name is Dr. Paul Verosi. I'm an electrophysiologist at the University of Colorado and the Rocky Mountain Regional VA Medical Center.
And I'm Dr. Javier Valle. I'm an interventional cardiologist, and I also work at the University of Colorado and the VA. We're both heart doctors who do the procedure to place the closure device. Depending on the team at your hospital, you may see a doctor like me,
Or like me.
or both of us. We're going to explain to you what the closure device is and how it can help prevent stroke.
The closure device is placed in the left atrial appendage to prevent the movement of blood clots from the heart to the rest of the body. One of the benefits of the closure device is that most people who get it can stop taking blood thinner medicine after a few months. This is true for 9 out of 10 patients. This can be helpful for certain patients: those who have a high risk of bleeding, those who have had problems with major bleeding in the past, or those who are active and worry about severe bleeding.
And about 30 days after having started my medication, I had a cerebral hemorrhage. And shortly after that, I was advised by a neurologist that I should never be taking a blood thinning medication again. The main drive for me to get the device was that I needed something that would at least reduce the chances of me having further strokes. I'd had two, and that was more than enough.
My doctor didn't suggest anything to me one way or the other. It was left up to me completely. She said, let's go over the facts, and we did. And I believe the Watchman would probably be a wonderful procedure sometime later on. I don't care to have it right now because I feel I'm doing good on medication.
Even though the main reason to get the device is in order to stop taking blood thinners long term, it's important to know that patients who get the device must be on blood thinners for a short period of time following the procedure. After 45 days, the doctor will determine whether or not the patient can stop taking blood thinners.
Initially, I was required to take warfarin after the procedure itself for approximately 45 days. After that, I was advised that I did not need to take it again or any other blood thinner except for aspirin.
Now let's go over the procedure to place the device and how it works to prevent strokes.
As we mentioned earlier, most strokes from AFib occur from a blood clot that forms in the left atrial appendage. To help keep blood clots from causing strokes, the closure device is placed in the opening of the left atrial appendage. The device is placed using a catheter or small tube that is inserted into a vein in the upper leg through a small cut. The catheter is guided to the heart. It enters the right atrium, crosses through a heart wall, and enters the left atrium. It can then get to the left atrial appendage. Once in place, the device acts like a lid over the left atrial appendage, preventing blood clots. This procedure is usually done with the patient under strong sedation, where the patient is lightly asleep, or general anesthesia, where the patient is fully asleep. Recovery from the procedure usually requires a one-day stay in the hospital.
The procedure was very easy. They went in through the vein into the heart and opened up the umbrella over the opening to that area where the blood clots, and it was very simple. Spent the night in the hospital and went home.
The closure device only prevents strokes from the left atrial appendage. If a patient has risk of stroke from clots in other areas of the body, like a mechanical valve, then blood thinners are the treatment of choice.
Comparing treatment options.
Let's now compare blood thinners to the closure device. Stroke risk is lowered about the same amount with both blood thinners and the closure device. As we learned earlier, the main risk associated with blood thinners is bleeding. The main risks associated with the closure device come from the procedure to place it.
Comparing blood thinners and closure device. Of those who take blood thinners, about 4 out of 100 people will have major bleeding each year. Of those who get a closure device, only about 1 in 100 will have major bleeding each year, but at least 1 out of 100 will have a procedure-related stroke, and at least 1 out of 100 will have procedure-related damage to the heart each year.
Additionally, it is important to note that the closure device is a relatively new treatment, and therefore we have less of an understanding of how well it works and the side effects over the long term.
Closure device. What we know and don't know. Closure device studies only compared the closure device to the warfarin blood thinner. Therefore, we do not know how it compares to the DOACs. Also, since the device is newer, we have less understanding of the long-term risks and side effects of the device. The procedure risks of the device are different from center to center. the risks are improving and occur less among doctors who have done the procedure many times.
As far as worrying about stroke risk on warfarin, I think my risk is lower. At least that's one of the reasons that I'm taking it. But I do think about it. I certainly don't want to have a stroke.
These are factors that you should consider when thinking about if the closure device is right for you.
Making a decision.
We've just provided you with a lot of information on how to reduce your risk of stroke because of AFib and the treatment options you may want to consider. There's a lot to think about when you're trying to decide which path is right for you. The choice of whether to get treatment, and if you get treatment, which one to choose is a very personal one and is based on your overall health, your goals, and your individual preferences. Ultimately, this is your decision to make, so take time to think about what matters most to you. Write down your questions or concerns and talk with your doctor.